This lecture is pelvic pain in women, a very common problem and a very perplexing problem, but a problem in which if the ultrasonographer or the physician really does a good job, provides a tremendous service to women. I'm going to put this in two parts. The first part is uterine pain, and the second part is other causes of pain. It's very important to ask the patient what's wrong. Find out where it hurts. She may well tell you the diagnosis. So talk to the patient. When assessing a woman with pelvic pain, it is critical to examine the patient, usually with the ultrasound probe, and then to answer the question. I emphasize that day in and day out with my staff. It's so important. Well, if you look at the requisition, what is the question? The clinical information we've been given is pelvic pain. The presumptive diagnosis is ovarian cyst or whatever. But remember, that's just a guess, albeit an educated guess, on the part of the gynecologist. But what are you being asked to do? Are you being asked to decide whether or not there's an ovarian cyst, or what you're really being asked for is, what is the cause of the pelvic pain? That is the question you have to answer, not is there an ovarian cyst or not. The patient came in with pelvic pain. You have to hopefully get her out of the department with an answer to what is causing the pain. The sonographer's job is actually to make the diagnosis. And if you don't, it's lost. Or is it? Well, the sonologist's job ideally is to report the findings in light of the total picture and then confirm the diagnosis. But they really have to see and examine the patient to make the diagnosis in light of the total picture. In the real world, I suspect only 10% of patients are seen by a sonologist. In some labs, of course, all of the patients are seen all of the time. In other labs, none of the patients are ever seen. But in the search for pelvic pain, it makes a huge difference. You have to ask yourself, what's tender? First of all, is the pain still there? I mean, when the requisition was filled out, may have been a few hours ago, a few weeks ago, a few months ago. Is the pain still there? Is it continuous or intermittent? Is it localized or generalized? Is it related to the menstrual cycle, such as dysmenorrhea? Is it related to intercourse, like dyspareunia? Is it related to the GI tract or to even the bladder? You have to ask all these questions. Really, it's a puzzle, and you have to solve the puzzle. Do you need a full bladder when you're doing the pelvic scan? Well, first we always do a transabdominal scan to look for a mass that might be outside the field of view, but then we always do the endovaginal scan because we can then examine the pelvis with the probe. So you don't need a full bladder, but you must do the endovaginal scan. And the endovaginal scan really is like an 8-inch extension of the gynecologist's or of the examiner's finger, because it allows you to examine the patient and, in fact, not only feel an organ, but actually see what that organ looks like. So this is a unique tool that really allows you to make the diagnosis. So when you're touching the uterus, when you're examining the uterus, press on the uterus. You have to be right on the uterus to know whether or not it's tender, and palpate the whole body of the uterus from the fundus down to the lower segment, from the right to the left, pushing on it and asking the question, does it hurt? If you just are touching the cervix, as in this case, you can't say anything about the rest of the uterus. The sonographer here has identified that the uterus was non-tender, but I would suggest that in fact you can't make that diagnosis by just pressing on the cervix. So here we have, starting off in the lower segment, then moving up to the fundus, touching the uterus, and as the sonographer has identified on the film, this is a tender uterus. And that's very, very important in trying to figure out exactly what's wrong in this patient. Here we have a patient with an acutely retroverted, retroflexed uterus, and you can see that here is the cervix, and really you're just touching the cervix, so you can't talk about uterine tenderness. But in reality, if you go behind the cervix, right on to the posterior serosal surface of the uterus, as you have in the next image, you can actually palpate the uterus and decide whether or not there is any tenderness. So don't just touch the cervix, whether it's retroverted or not. You have to actually touch the body of the uterus. Here's another example. Here you can see a nice anteverted uterus, a full bladder, and you can see on the endovaginal examination, the sonographer is touching the anterior lip of the cervix, you can see in this diagram. Well, you can't tell anything about the uterus by just pressing on the cervix. So unless you're touching the uterus itself, don't talk about anything. And here she said that it was non-tender, but in fact you just simply must discount that. You're pushing on the anterior lip of the cervix, and that just simply doesn't count. Well, in the midline we have the various organs. We have the urinary bladder, uterus, and then we have bowel behind it. In the adnexa you have the tube and the ovary, and then you have other things such as bowel, retroperitoneal structures, etc. Here you can see in the left lower quadrant, you have the sigmoid colon, a source often of pelvic pain, but due to bowel. In the right lower quadrant, you have the terminal ileum and you have the appendix, another source of pelvic pain not related to the uterus, tubes, or ovaries. And these have to be identified. So the normal uterus, you have nice endometrial canal, the body and cervix. You have here the fallopian tube and then the ovary, in this particular specimen in the coronal view. Here you can even see a remnant of the Wolffian duct, a small paratubal or paraovarian cyst.